Good evening, everybody. It is my pleasure to invite you for this Delhi Molecular Oncology Group webinar series, which is organized by Oncology Forum. And today's topic is based on the very important aspect what we see in the clinics, that is the carcinoma of unknown primary. And we will be talking on the aspects, that is the molecular aspects of. Is my voice clear?
It's very clear, sir.
Okay, perfect.
Yes.
So we will be talking on the molecular aspect of carcinoma of unknown primary. And to address the different aspects of carcinoma of unknown primary, we have various experts from various spheres. Dr. Julka is not available, so I'm just taking up the discussion from there itself. And we have Dr. Ajay Vyas, who is our first speaker, who is a senior consultant in the Department of Nuclear Medicine at Max Hospital. And he will be talking on the role of molecular imaging in CUP. This will be followed by a role of molecular diagnostics in CUP. It will be taken by Dr. Rajiv Tangri, who is a national head histopathology and cytopathology at Lal Path Lab. We also have an international speaker, Dr. Michael Foss, who will be talking on the role of molecular profiling in CUP, who is a medical science liaison from Caris Life Sciences. It will be followed by a panel discussion moderated by Dr. Raj Saha, and we have esteemed panelists. Along with the speakers, we have Dr. Arun Goyal, as well as Dr. Piyush Bajpai and Dr. Ashna Lal from Lal Path Lab as one of the panelists. And we'll start the session now. I invite Dr. Ajay Vyas to take up the discussion, and he will be talking on the molecular aspect of imaging in carcinoma of unknown primary. Dr. Vyas, up to you.
Yeah, good evening, everyone. I am Dr. Ajay Vyas.
I would request everybody to mute themselves. I can hear some disturbances. And for any questions, we can either have the discussion during the panel discussion, or we can have questions in the chat box.
So, Dr. Amit, I am not able to share my screen. Can you please?
Nidhi, can you help?
Yeah. Right now. So, good evening, everybody. I am Dr. Ajay Vyas. I am a nuclear medicine physician and in the Max Hospital, Delhi. And today's topic of discussion is role of molecular imaging, especially PET-CT in carcinoma of unknown primary. So as you all know, carcinoma of unknown primary is basically is absence of clinically detectable anatomically defined primary tumor, often an adequate diagnostic evaluation. So basically can be considered as a diagnostic failure. But right now, due to improved clinical diagnostic techniques like CT, MR, PET-CT, and even endoscopies, we can find more primary anatomical site as compared to the past. Right now, we have a pathology with modern ISC and genetic testing to find a more site of primary sites. So, CUP patient with there are two subsets you all know, favorable subsets and unfavorable subset. The site-specific therapy have a better prognosis as group as a whole, and in case of absence of definitive diagnosis, is about 80% of the patient unfavorable prognostic group. The median survival is quite low, is 9 months basically. So to detect the site of primary is very important, and definitely improve the prognosis of the patient. So there's a US data, they find about 50,000 patients per year in USA with CUPs. Most of the patients have a carcinoma, and adenocarcinoma is the most common one. As I mentioned previously, the favorable subtest about 20% of CUPS cases. So histopathological major histologies in case CUP, well to moderate differentiated about 60%, poorly differentiated adenocarcinoma or carcinoma is about 30%, and very low neuroendocrine 2%, and undifferentiated malignancy is also seen in 3% of cases. So there are few fundamental characteristics of any CUPS case. Basically, there's first is a clinical absence of primary as presentation, early dissemination, aggressiveness, and unpredictable metastatic pattern. Because of all these characteristics, to find the primary is very important. And what is the optimal investigational diagnostic approach for the identification of primary tumor? So first of all, we have to see the clinical landscape of CUP over decades. Like in 70s and 80s, we don't have CT or MRI. It is very difficult to find the primaries. And right now in this era, we have a PET CT, MRI, endoscopic ultrasound, and this can improve the site-specific therapy, basically based on the accurate diagnosis of the primary site. So right now we have different modalities to find the primary. Evaluation and management of possible CUPS patient. Imaging has a major role to find the anatomical primary site. If the primary site is identified, we can give a very site-specific therapy. And as we discussed earlier, prognosis is better. So if we see what are target patient population assessment required, we required a medical history and physical examination for all the patients, basic blood and biochemistry analysis in all the patients, CT scan, thorax, abdomen, pelvis in all the patient, or right now, if F18, FDG, PET CT, whole body PET CT, even it is more cost effective nowadays as you compare with the thorax, abdomen, and pelvis, and is also available in right now in 2-tier cities. Workup with CUP subset, breast MRI in patient females with axillary lymph nodes. If the AFP and SCG is raised in patient with a midline metastatic disease. Serum PSA, right now we have a PSMA PET CT scan. We have a PSMA PET CT scan in case of males with a bone metastasis. And in the case of head and neck subsets of CUPS patient, PET CT is definitely useful. And in case of plasma chromoglobin increased levels and with a patient with a neuroendocrine primary and neuroendocrine metastasis, DOTATOC PET CT is the scan of choice nowadays. So not only the imaging is not only important to find a site of primary, even it's become as a baseline for the initial therapy, and we can stage the tumor also, even the therapy response, restaging, and even in some cases we know the site of biopsy also from the PET CT scan, and has a major role in RT planning also. So first we go through initial image, all the imaging modalities, then followed by PET CT and few live cases. So conventional imaging like X-ray, mammography is basically not enough. For the role of evaluation, tumor cases is very limited, and we don't get any very good information for bone, thorax, and is not enough for to find a primary. Ultrasonography is definitely easily available, cheap, it gives real-time information, but it's not a standard tool for a tumor evaluation because it lacks the complex informations, lack the bone evaluation, and difficulties evaluation of deep structures. But is a very good modality to for the US guided biopsy. Drainage is important for the biopsy and drainage site. So is excellent for the soft tissue solution, but this definitely lacks the complex information. CCT or multi-dimensional CTs, right, is a main imaging tool for the tumor evaluation, and can gives all the complex information for the tumor. Right now, the PET-CT scanners come with multi-slice CT scan. So in the present PET-CT scanners, we have a PET as well as multi-dimensional CTs. So basically, is a main model. CT is one of the main modality for the tumor evaluation, and even for the guided biopsy and drainage is very good for the bone and basically lung nodules. We can do a 3D reconstruction also in case of head and neck cancers. And right now there's virtual endoscopy and CT angiography also for the operabilities. So a few words about MRI also. For the brain tumors and for the pelvic tumors, MRI has a upper hand over the CT scan or PET-CT, and is also tell about the operability versus inoperability. For brain, hepatobiliary, gynecological tumors, rectal tumors, MRI is must. So comes with the PET-CT. PET-CT is basically a fusion of positron emission tomography and computed tomography. So PET gives the metabolic activity and CT gives the basic of advanced anatomical information. As we discussed earlier, is not only to know the diagnosis of the tumors, also important for the baseline as well as therapy response, recurrence, restaging. Right now, PET MRI is also available. It shows very promising data, especially for head and neck and pelvic tumors. So if we divide cups as far as imaging is concerned, we get most of the patient of cups, about 50% of the patient we get from head and neck side. So we have a special word for the head and neck cancers. Patient with head and neck cancer, and sometimes they present with metastatic squamous cell carcinoma, cervical lymph nodes. And despite of all the efforts, about 2 to 9% of the patient comes with a nodal metastasis, have an occult primary site. So all the PET-CTs now we have a special resolution of about 6 to 7 mm. If the size of the primary tumor is less than that, we are not able to find the primary site in PET-CT nowadays. So as you all know, the primary tumor is found, patient can be afforded the tissue sparing offered by the modern focused radiation therapy techniques, and they have a very low morbidity of xerostomia and fibrosis and head and neck cancers. So there are different meta-analysis. There are mostly CUPS patient, role of CUPS patient in the PET-CT. There are two subsets, as I told earlier, head and neck cancers and other. So in all practical point of view, we only find 1/3 of the primary sites in head and neck cancers. In 2/3 of the patient, we are not able to find the site of primary by the PET-CT. So right now we start discussing the cases. So is a 68-year-old male comes with right cervical lymph node metastasis. This is a CT scan image of the patient. You can see bilateral tonsillar thickening in these images, but we are not able to find the site of primary. MRI also done in this patient. This shows left tonsillar lesion with irregular margins. So it looks like a left tonsillar primary with lymph node metastasis, but the PET-CT was done for the same patient, shows bilateral tonsillar tumors with lymph node metastasis. So here PET-CT have an upper hand over the MRI and CT scan. Another case, so is basically a 41-year-old woman with metastatic squamous cell carcinoma on the left side of the neck. CT scan of the patient shows no site of primary. MRI also is not able to find the primary in the patient. PET-CT was performed, and there's no FDG lesion in the oral cavity or buccal mucosa, and PET is not able to find the site of primary in the patient. And histologically, there is a tumor at the base of tongue on the left side in this patient actually. So PET is not able to find the primary in this patient. Another patient, 50 years old male, presented with metastatic left cervical lymph nodes. And here we see PET CT was performed directly. And you can see there's a primary in the nasopharyngeal wall, right posterolateral wall and fossa rosemola is a site of primary with bilateral cervical lymph node metastasis. This is physiological FTG uptake in tongue muscles, bilateral symmetrical, and the site of primary is nasopharynx. And if we see ROC curve in the subsets of head and neck squamous cell carcinoma, PET CT has a upper hand over the CT and CT plus MRI alone. PET CT can detect more site of primary if we compare with the CT and MRI alone. This is another interesting case. It's a case of carcinoma right tonsil with lymph node metastasis. Simultaneously, there's a synchronous second primary NHL with abdominal lymph nodes in the same patient. So this is the usefulness of whole body scan actually in patients of even head and neck cancers. So we can discuss more cases. There's a 50 years old female presented with left axillary swelling, multiple axillary lymph node detected on ultrasound, mammography shows by RES2. What is the site of primary? These are the coronal images of the patient, shows multiple and large FDG with left axillary lymph nodes. And in the axial images, we can find a very small primary in lower inner quadrant of left breast with multiple and large axillary lymph nodes. So by the PET CT, we can find the small primaries also. Another case, patient presented with malignant ascitis, and PET CT was performed. It shows a primary as an stomach with ascitis and lymph node metastasis. 65-year-old female with ascitis. In this case, actually, PET CT is not able to find a primary in the patient. So after the laparotomy and pathological confirmation, this is basically from the right ovary. So PET is not able to find the primary. This is basically omental caking with peritoneal deposits and ascitis, but PET is not able to find the primary in this patient. Is a 71 years old male with metastatic left supraclavicle lymph node. PET CT was performed. The primary site is basically prostate. Primary prostate with multiple lymph nodes and skeletal metastasis. So right now, for the neuroendocrine tumors, we have Dotanoc tracer, and very useful in case of neuroendocrine tumors. A patient comes with multiple liver lesions with a raised chromoglobin level. Upper GI endoscopy, colonoscopy is normal in this patient. And the site of primary is basically proximal jejunum. These are the coronal images. These are the proximal jejunal loop to the site of primary. You can see announcement on CT also with multiple lymph node, multiple liver metastasis. So that's why I was not able to find the primary or upper endoscopy and colonoscopy in this patient. Another patient with raised chromoglobin levels and multiple liver lesions. The primary is head of the pancreas, but is not compressing the CBD, and there's no IHB dilatation in the patient. So few live cases. A patient is a very recent patient, actually 73 years old male with multiple cutaneous lesions in scalp, face, and palm. And the biopsy shows a squamous cell carcinoma. In case of cutaneous lesions, we, as a nuclear medicine physician, we always think about the carcinoma of lung. But the site of primary in this patient is basically esophagus. Site of primary in this patient is esophagus with adrenal metastasis, bone metastasis, and multiple cutaneous deposits. Another patient with enlarged prostate and raised PSA levels. PSMA scan is performed in the patient. I can show. Sorry, I'm not able to hide the name of the patient in this case. So PSMA is basically very specific for prostate carcinoma with very few false positive and negative. So this is a PSMA scan of the patient with the raised.
We are not able to view your screen. It's half screen.
Okay. Right now you can see my screen? No?
No.
Okay.
The screen is visible, but it is only half screen. So you have
Half
to
screen,
do the
half
screen
screen.
show.
Somehow you have to make it a slideshow once again.
Okay, sir. This one, right? You can see.
And there is some scribble on the screen. What is it? Where is it coming from?
Annotation off करना पड़ेगा उसका.
Okay, sir. So if you permit me, I can take a minute to settle this. Right now, my So, Dr. Yes, right now you can see the entire screen, or still you're not able to see?
Sir, only half screen is in.
Okay. So I think it's because it takes more.
Yes, sir, full screen.
Now it is okay.
But go to screen show.
Okay, sir. Right now you can see, sir? No.
No, sir.
So there's some problems, sir. So I can. So in our setup, we find most of the primary from the lung and lower GI tract in PET cities, and very few from the breast and prostate, because right now from the digital mammography and MRI, they can pick up the breast lesions, small breast lesions also. So PET CT is an effective modality to detect the primary tumor site in the patient with the cups, which facilitates early selection and appropriate treatment protocol, and that definitely improves the patient prognosis. There are different meta-analysis in role of PET CT for detection of primary, and the detection site ranges about 22 to 73%. But practically speaking, is basically about in head and neck cancers we can pick only 1/3 of the primary sites, and beside head and neck cancers we can pick about 60%, about 2/3 of the patients. And the sensitivity of PET CT is also wide range because of the inclusion and exclusion criteria, but is definitely one of the best modality available for the primary site. Thank you.
Thank you, Dr. Vyas. So if if somebody want to ask any question, they can put on the chat box.
Okay, sir.
I don't see any questions. So we'll take up the questions in the panel discussion, Dr. Ajay. And thank you very much for a wonderful talk and quite comprehensive, including very interesting clinical cases.
Yeah.
And I think we also learned the clinical utility of the rotor knock PET CT for the QUP, which we do not think that much in our clinical setting. So thank you very much for that.
Thank you, Dr. Ahmed.
And Dr. Urmi, who is the chairperson of this session, has joined. So she needs no introduction. She is a senior director and head histopathology at Max Hospital. And Dr. Urmi, can you hear us? Hello. So never mind, I think she's not able to listen to our discussion. So I would invite Dr. Rajiv Tangri as a next speaker to talk on the topic of the molecular diagnostic aspect in CUP. Dr. Rajiv Tangri, please.
Thank you, Dr. Amit, and thank you, Oncology Forum, for this opportunity. I would share my screen now. Yeah, can you view my screen in slideshow mode?
Yes, sir, we can see you.
Yes.
Yeah, thank you. I'll start my presentation. So my topic for today is role of immunohistochemistry in diagnosis of carcinoma of unknown primary. So Dr. Ajay has already told us about role of PET CT and radiology in diagnosis of CUP. So I would very briefly, before going to the actual topic, I'll take half a minute to discuss about immunohistochemistry. So immunohistochemistry is basically, the principle is antigen-antibody reaction. The antigen is present on the tissue, on the cells, and that is what is detected by putting external antibodies in a external environment. Now, quickly skip this. This is how it works, the principle, and this is how the slides would look like. Now, the antigens can be present anywhere, and the antigen, they have, their localization is very specific. So some of the antigens are present on in the cytoplasm, some are present on the cell membrane, some are present in the nucleus. So positivity has to be seen in those specific locations only to call something as a positive or a negative. Now, coming directly to our topic of today, which is carcinoma of unknown primary, which has already been defined as the primary, where the primary remains microscopic or disappears after seeding the metastasis. So how does immunohistochemistry helps us in diagnosing CUP? That is what we will see. The antibody algorithms are commonly used to arrive at the diagnosis in such cases. And these algorithms help us to search for the primary, to rule out non-carcinomas, and to identify subgroup of tumor for the purpose of treatment. Now, these algorithms can be designed broadly, I mean, based on the clinical information which is available to us, the radiological findings, clinical findings, and also after we see the routine HE slide of a case, we would make some interpretation of the, or some idea in our mind what the primary site could be. So based on that information plus the clinical information, we make these algorithms. And the algorithms, there are commonly available algorithms available in textbooks, articles, but usually these are tailored from case-to-case basis. So we'll discuss it further a little later. This is the basic flow chart, how we proceed in a case of CUP. when we do immunohistochemistry. There is a first round of IHC antibodies which are put, which are usually the broad antibodies, and which decide the lineage of the cells and rule out the non-carcinomas wherever it is very, very undifferentiated tumor. The second round would help us in further reducing that list of differential diagnosis, and maybe a third round is required in some cases, wherein we finally arrive at the diagnosis. Something explained here. So the stepwise approach is, as I said, the first step would be the cell of origin of the tumor has to be determined, and non-carcinomas have to be ruled out. Then we determine the type of cytokeratin distribution in the tumor cells, followed by expression of supplemental tissue-specific and cell-specific markers, focusing on the tumor differentiation. So this is the broad table that is used in a case where something comes as a cancer of unknown origin or unknown primary. So to rule out sarcoma, melanoma, lymphoma, and germ cell tumors and mesotheliomas, as the case may be, depending on the clinical inputs and the morphology of the case, we will put cytokeratin, LCA, S100, or SOX10, SAL4, or LIN28, and Vimentin. So this is the first set of markers that we usually put in such cases, followed by differential cytokeratins. Now, I'm discussing this three-step approach, but in a practical setting, there is a lot of overlap between these steps based on the morphology that we see on light microscopy and the clinical findings that we already have in these cases. We may combine all these markers together, step 1 plus step 2, maybe some step 3 markers also in the first step only, just to cut short the timing. So the keratins are very important in a case of carcinoma of unknown primary, because a combination of CK7 and CK20 will usually distribute give us a differential between the 4 buckets that we have. So these are the 4 buckets: CK7 positive, 20 positive, both negative, 1 positive, 1 negative. So we have a long list. This list is not complete, but yes, we have a longer list of all the carcinomas that fall into each of these buckets. So once we know which bucket our case falls into, further set of specific cell-specific and lineage-specific markers can be put up. Just to give an example, a metastatic colonic carcinoma in lung would be CK7 positive and 20 negative, while a lung carcinoma will be CK7 positive and 20 negative. So these 2 markers are very important in a case of carcinoma of unknown primary. These were the simple keratins. We have complex keratins as well, which are the cocktail keratins like CK56, which is a very good indicator of squamous differentiation and transitional differentiation, along with P63, which is another marker, and high molecular weight keratin 34 beta E12, which is again a cocktail marker, and it's again a strong marker of squamous differentiation, as well as it also highlights the basal cells and myoepithelial cells in it and breast. Now, I would take up a few cases, actual cases also alongside, so that it gives a better clarity on what I'm talking about. So, for the 62 years male cervical mass, FNAC was positive for malignant cells. On FNAC, we could not differentiate between lymphoma or metastatic carcinoma, so a biopsy was done. This is how it looked on light microscopy. It's a poorly differentiated carcinoma. Could be anything, but squamous it is one of the possibilities here. Pancytokeratin was positive, CK7 was negative, 20 was negative. The cells was smallish, so Synaptophysin was also done to rule out neuroendocrine differentiation. P63 and CK56 were positive. So as I said earlier, these two are markers of squamous differentiation. So this was a metastatic squamous cell carcinoma. This is how just a combination of cytokeratins helped us in arriving at a diagnosis, which was a rather simpler diagnosis as far as IHC diagnosis is concerned. But we must remember that I mean, nothing is absolute in immunohistochemistry. There are a lot of anomalous expression of cytokeratins in many non-carcinomas like sarcomas, melanomas, astrocytomas, especially high-grade gliomas, meningiomas, plasmacytomas, dendritic cell tumors. The cytokeratin can be positive. So we cannot just depend on cytokeratin expression in a tumor to diagnose a case. Next comes the role of vimentin, which is not a very useful marker now, but yes, it is helpful in some cases. Vimentin otherwise is seen as a marker of mesenchymal differentiation. Some carcinomas do express vimentin, and that helps us in differentiating it from few other carcinomas. Like between endometrial and endocervical, endometrial is more likely to have co-expression of vimentin. RCC is known to have vimentin differentiation. So these are some of the cases where vimentin can help us along with cytokeratins. Now we come to the organ or tissue specific markers, which finally help us in clinching the diagnosis. So organ specific markers, they are high specificity markers for certain tissues and enable us to find focus research for region of metastasis. I have enumerated here a list of markers for different organs, but again, this is not all-inclusive list. The list is much, much longer. But one thing I would like to highlight here is that again, I mean, we call these markers as organ specific or tissue specific markers, but there is a lot of overlap. You can see GATA3 is positive in breast as well as in TCC. PTF1 is positive, can be positive in lung as well as thyroid. PAX8 can be positive in gynecological cancers, ovarian cancers, renal cell carcinoma or thyroid. P63 and P40 in urothelial as well as squamous carcinomas. So there is a lot of overlap between the markers of so-called cell-specific markers as well. So it is important here to note that more than one marker is usually required to be put on a case for a given cell-specific antigen so that we arrive at the correct diagnosis. Talking about the algorithms, which I touched upon earlier also in my presentation, there are some algorithms. These are some of the algorithms that we use for differentiation between endometrial carcinoma and endocervical adenocarcinoma. So ERPR, P16. Similarly, urothelial versus prostate carcinoma, which is a common dilemma in many cases. So we use a combination of CK7, CK20, P63, GATA3, and NKX 3.1. Differentiation between various types of ovarian carcinomas, low-grade serous, high-grade serous, mucinous, endometrioid, and clear cell carcinoma. We use a combination of PAX8, WT1, P53, and ERPR. IHC also helps us in differentiating carcinoma from a non-carcinoma, like in prostate, wherein a combination of a marker P63 and CK56 can help us in differentiating these. Renal cell tumors with clear cytoplasm, there may be various differential diagnoses: clear cell RCC, papillary RCC, chromophobe RCC, clear cell papillary RCC, epithelioid angiomyolipoma. So we use a combination of various markers to arrive at the final diagnosis, including CA9, a marker, CD117, CD10, PAX8, CK7, HME45, and Melan-A, depending on the morphology, of course. I mean, we may use all the markers and we may use some of these markers only. These are some more common algorithms which I have taken from some of the textbooks and articles. And as I said earlier, we can tailor these these algorithms depending on whatever clinical information and radiological information is provided to us, combined with what we see on light microscope. We feel that primary site could be based on the light microscopic examination of the tumors. Some more algorithms. Various such algorithms are available. Now, we have discussed about the stepwise approach. Now I would talk about a few more cases, just to show how IHC helps us in arriving at a diagnosis in carcinoma of unknown primary. This was a 55-year-old male. Constipation and bleeding PR were the symptoms. There was a rectal mass for which the biopsy was done. So we did IHC apart from other markers, pancytokeratin, LCA, pancytokeratin and LCA were negative. As I showed in the first step, we do the lineage specific markers. So out of that, S100 was positive. So HMB 45 was also put up, which was also diffusely positive in tumor cells. So the diagnosis was malignant melanoma of anal canal, which is presenting as a mass in rectum. Case 36 years old male presented with vague gastric fullness, CT submucosal gastric mass. The clinical diagnosis was carcinoma versus GIST. So the set of markers that were put up apart from a few other markers. Pancytokeratin was diffusely positive. Synaptophysin and chromogranin was positive. The tumor, though was, had a small cell morphology, but there were epithelioid areas also. So even CD117 was put up. That was a clinical differential diagnosis as well. Based on the IHC markers, the final diagnosis was neuroendocrine carcinoma, grade 2. Another case, 62 years male, presented with breathlessness, chest pain. On PET CT, there was FDG-avid lung mass in lower lobe, 1.4 centimeter in largest dimension. True cut biopsy was done. Differential was between primary lung carcinoma and metastatic carcinoma. So pancytokeratin was positive. CK7 was negative and 20 was positive. 7 negative goes to points against lung carcinoma. Further markers were done. Synaptophysin was done, which was negative. CDX2 was positive in this case. So it was actually a metastatic colonic carcinoma in lung. Another case, 49 years female, breathlessness, cough, in lung and kidney. True cut biopsy was done from the lung lesion, which was more approachable. So it was clinically, the diagnosis was primary lung carcinoma versus metastatic carcinoma. It was a small, very small biopsy. Most of it was necrotic, but there was a small bit of viable tissue wherein the markers showed both CK7 and 20 negativity. So our differential diagnosis was limited to the bucket of 720 negativity, and we did some more markers on that side. CD10 was positive in this case. PAX8 was positive in this case. So we did CA9 as well, which was also diffusely positive in the tumor cells. So the diagnosis was metastatic clear cell in lung. Another case, 55 years male, hematuria, urinary tract symptoms, prostatomegaly, PSA was 6.4. So trust guided biopsy was done from prostate. HE was very undifferentiated tumor. I mean, there were no SNR areas in on light microscopy. So IHC was done, and CK7 and 20 both were positive. Now prostate has to be negative for both CK7 as well as 20. So both were positive. We did GATA3, 3.1, GATA3 was positive, NKX was negative, P63 was also positive. So I showed the algorithm prostate versus bladder. So this was actually a urothelial carcinoma which had spread into the prostate. As I talked earlier, IHC also helps us in differentiating between benign and malignant, especially in prostate. So a marker, CK56 and P63 are the three markers which we use in combination in all the cases. So this was a case wherein on light microscopy, we could not say for sure whether it was actually a carcinoma or not. So we advised immunohistochemistry, and on immunohistochemistry, the marker was positive, and CK56 and P63, which should highlight basal cells in the benign SNI, were negative. So there was no basal layer. So that indicated that this was a SNR adenocarcinoma of prostate. So we talked about the diagnostic utility of IHC in carcinoma of unknown primary. Now, moving a bit ahead of this, IHC is now also being used as a theranostic for the theranostic purpose. So, it helps us in personalizing the target cancer therapy. The monoclonal antibodies, TKIs. So HER2 has always been used. I mean, for decades, been used for this. EGFR for lung carcinoma, L-cross, and now PD-L1. Now, PD-L1, more and more approvals are coming from FDA for its utility in carcinomas. So, I mean, we can use PD-L1 depending on the, if finally we even if we are not able to arrive at the actual primary site, if so, depending on the morphology, depending on the location of origin, location of the cancer, we can use targeted therapy based on the PD-L1 expression of the tumors. So I'll talk a bit about PD-L1 also, not going into details of the theory of PD-L1. PD-L1 is an immune-related biomarker expressed on many normal tissues with PD-1 receptor on T cells. So when there is binding between PD-1 and PD-L1, the T cells are downregulated. So there is no killing of the cells which express PD-L1. So sometimes the cancer cells, they start expressing PD-L1 and they escape this killing by the killer T cells. So any target therapy against PD-L1 or PD-1 that interrupts this pathway can have a attractive therapeutic responses in the patients. So testing for PD-L1 expression can help in identifying the patients who will benefit the most from treatment by PD-L1 inhibitors. We must remember the two terminologies given by FDA: companion diagnostics and complementary diagnostic. Companion diagnostics is for where the testing for PD-L1 is mandatory before we use a drug for a particular malignancy, while complementary or co-diagnostics is where the testing is not mandatory but recommended before using a drug for PD-L1 therapy. So here's a long list of various malignancies, for which FDA has approved the treatment by PD-L1 or PD-1 inhibitors. And there are multiple, there are different clones of PD-L1 antibody also, which are used for against each of the different drugs. So for Tecentriq, it is SP142. For Imfinzi, it is sp263, and for Keytruda, it is 22C3. For Opdivo, it is 28-8 or sp263, but most of it is complementary. Now, some of these are complementary for others, and some are companion diagnostics. And we must also remember that the reporting that we do for PDL1 for each of these varies on the type of malignancy and the clone that we are using for testing. Like in some cases, more than 1% would be positive. Like when we use clone 22C3 for non-small cell carcinoma, any expression more than 1% is considered as positive. While when we use sp263 for urothelial carcinoma, more than 25% is considered positive. sp142 for non-small cell lung carcinoma, more than 50% positivity is considered as positive. Now, the second point to remember here is that positivity also can be in tumor cells or immune cells. But then FDA has given us guidelines where to see for positivity in which tumor type against which clone. So this table enumerates all those in details. I won't go into greater details of these.
Dr. Rajiv, can we wind off quickly because we are running short of time?
2 minutes.
Yes.
Okay. So these are the 3 clones. IHC is also helpful in now in genomic classification of colonic cancer, in gliomas. Newer markers are come up, which help us in classifying the tumors, like TFE3 in XP11.2 translocation carcinomas, renal cell carcinomas, H3K27M for diffuse midline gliomas, IDH mutant gliomas, IDH wild type gliomas. So now classification is now based on the new immunohistochemical markers. Very quickly, there are some limitations of IHC also. The specificity, as I talked earlier, also there is a lot of cross-reactivity, lot of overlap. There can be non-specific absorption of antibodies in necrotic tissues. There can be entrapped non-neoplastic elements. So how to take care of that is adequate fixation, which is the most important thing that will help us. So fixation has to be adequate. Fixation has to start immediately after the surgery, as soon as the tumor tissue is removed from the body. Sound knowledge of anatomic pathology, good communication between clinician and pathologist. Can talk hours for that. Availability of complete battery of immunomarkers and avoiding limited markers. These are the keys to avoid these limitations. Very quickly, this is the last case, 16 years male, thigh mass, large mass, 6.5 centimeters. Clinical diagnosis was sarcoma. This was HE, which was, there were areas which looked like carcinoma. There were areas which looked like sarcoma. So, carcinosarcoma was the diagnosis on light microscopy, of course. But when we did IHC, everything was negative except for pancytokeratin and vimentin. There was some non-specific staining for some of the markers like CD99, but then, we did almost 20-25 markers in this case and nothing was coming positive. Upon probing, it was found that there was a large lung mass in this case. So going back to HE, the diagnosis was actually pulmonary blastoma, which had metastasized to thigh. So the idea of showing this case here is that IHC is not always helpful. There may be some cases where even extensive IHC may not be helpful in arriving at a diagnosis. So good knowledge of histopathology is very, very important. So I'd like to end with this statement: the diagnostic power of any Thank you. This is my place of work, National Reference Laboratory, Dr. Alpat.
Thank you, Dr. Rajiv. A very comprehensive talk. And I think the extra work what a pathologist has to do to reach to a diagnosis is quite evident with the plethora of biomarkers which are available. And I think, may I ask everybody to mute themselves? There's quite a disturbance here. So we'll ask the next speaker, Dr. Michael Foss, to share his screen and start his talk. Dr. Michael.
Hello, everybody.
Hi. Dr. Michael will speak on the molecular profiling in the carcinoma of unknown primary.
So I guess you can see my screen, can you?
Yes.
Okay, all right.
Yes.
So first of all, hello, everybody, and thank you for the opportunity to speak today. Just give me a second, please. Okay, so my topic for you today is the role of comprehensive molecular profiling in the management of cancer of unknown primary. But first of all, please let me introduce to you very briefly our company. It will be brief, I promise you, but at least a little bit of background. So Caris Life Sciences is a privately held company which is utilizing multiple diagnostic technologies to provide clinically actionable information for solid tumor patients. So basically, there is much information on this first slide, and I will just focus on the most important thing. And the most important thing is that we are a company which is not a big pharmaceutical company producing drugs in parallel and having a precision medicine department. We are only doing precision medicine, so meaning only doing diagnostics. So this is our only business, and we are specialized in this. We are not producing drugs or anything like this in parallel. It's important to mention, I think. The next point here is, so basically it's a central message. It's that we are using multiple diagnostic technologies, meaning we are not only sequencing DNA, we are analyzing DNA, RNA, and proteins. And this is crucial specifically for the talk today in the cancer and the management of... There's some noise. Thank you. Could you please go on mute? There's some strong background noise. Okay.
अगर मिल गया तो ठीक है 7:30 तक हैं किसी से पूछा तो वो कर भाई थोड़ा पेशेंट तो हैं बंदे भी हैं अगर इस टाइम
there are people talking.
May I ask everybody to mute themselves, please? There's a lot of disturbance.
वो कहते हैं अभी है थोड़ा बहुत टाइम आ जाओ
I think organizers.
अगर 7:30 तक पहुंच जाओगे तो शायद तुमसे मिल लें.
The host can mute everyone.
ये कौन जाएंगे?
आर्थिक बंद नहीं रहा है रोशनी आता है ना ये. Nidhi, you can mute everyone as a host. Now.
Okay, thank you. So I was at the I was at the central point. So the central most important point here, basically, what we are doing is we are not only analyzing DNA. So we are analyzing DNA, RNA, and proteins. So we are doing a real profiling. The reason why this is important is basically the main topic of today's talk. So comprehensive profiling in the management of cancer of unknown primary. So let's continue. So here is our numbers of publications. So you see it's a very strong output in the year 2020. So 17 presentations, publications, so 14 at ESCO, 3 at ESMO. Then I would like to tell you that we have a very strong database of over 215,000 connections of, on one side, it's the profiling data with the clinical outcome data. The reason why this is important is because this is basically the fundament why we are able of producing artificial intelligence-based predictors, but we will come to this later on. So why are we so far advanced? Why are we doing what we're doing? And where does this come from? So the answer is, it's not us alone. Basically, what we are doing is we are coordinating a research network of 48 leading cancer centers around the world. So mainly of them are localized in the USA. So now you see a little bit the infrastructure of our company, what is our philosophy, where it's coming from in our science. And basically as an outlook, and then let's start with cancer of unknown primary management. It's so because right now we are still focused on solid tumor biopsy analysis, which is the gold standard in oncology, as you know. As a complementary, very precious technology, liquid biopsy is becoming more and more important. And we will bring out this year, we will commercialize our liquid biopsy, which will also analyze DNA and RNA and be the most comprehensive on the market as well. Then we will also focus as an outlook more on artificial intelligence-based predictions. So now this was part one. So let's come immediately into the topic. The first question is the determination of the primary enough for CAP management? So in other words, when it's not a CAP anymore and you are trying to treat your patient with chemotherapy, could it be enough? So there are several publications, but I'll show you this one, and probably all of you know it already, but the short answer is no, it is not. So here, for instance, this publication, so no significant survival benefit with site-specific versus empiric chemotherapy. So if it's like this, what should you do then? So basically, the thing is the following. This is kind of a two-key system. You have to see it like this. So on one side, you have the key of the diagnosis. Of course, it is precious, and of course, it is necessary to clarify where your cancer of the unknown primary is coming from. So we discussed this already in the first speeches we heard today, and basically it's clear. But as we just saw, you also need, on the other side, an understanding what's going on in your tumor. So do you have actionable alterations? And in order to understand, so to have these two keys together, you need a comprehensive profiling. So DNA, RNA, and protein. And why this is so, and section by section, we will discuss this today in my presentation. Just on a side note, if you have a comprehensive profiling, then of course, both are linked. So the diagnosis to the comprehensive profiling, because either you are able to diagnose your patient and you have then a specific lineage, for instance, breast or colorectal cancer, something like this, then the target drug associations will change and you have different level of evidence. This is also the reason why, for sure, you need your diagnosis. It's obvious. But if you are not able of doing so, then you can say that, perhaps to say it in a kind of simplified way, cancer of the unknown primary could be considered as a kind of tumor agnostic model. To say it like this, because at the end of the day, you can say it's like this. So let's start. If you want to understand what's going on in your cancer of unknown primary, it's the same as for every other cancer as well, from the point of view that you have to go back a little bit and to think about how will you address this, what's going on and what's happening. So very briefly here. So the system is the following. The system are cells which are deregulated. But what are cells? Cells are biomachines. Biomachines which are made up of protein signal transduction cascades, which are then interconnectedly linked. Yes, all of us, we know this. Of course, this is trivial. But the reason why I'm telling you this is because if you think about it now from the bird eyes perspective, how are these signal transduction cascades made of? And at what point do you have modifications which you could potentially target? So basically what I'm telling you is, of course, it's going from DNA to RNA to protein. And at every level, to build up these signal transduction cascades from our machines, which we want to fix or target, different alterations, you have at every level, you have different alterations. So if you want to understand what's going on, you need to analyze DNA, where you can have mutations, insertions, etc., RNA, alternative splicing, regulation of expression, protein as well. So if you want to understand what's going on, if you want to find what's going on clinically, actionable alterations, you need to analyze DNA, RNA, and protein. This is the reason why we are analyzing DNA, RNA, and protein. But we will come to every part with examples and drugs and everything today. So let's start with DNA. To be very brief, so we have whole exome sequencing. So we are analyzing every 22,000 genes. Then RNA, same. We're analyzing every transcript, so whole transcriptome sequencing. And in addition to this, we are analyzing proteins. And in addition to this, we have artificial intelligence-based predictors, which will then integrate this information and analyze molecular signatures. So let's start with the first part. How can this help you in the diagnosis part? Basically, if we are talking diagnosis, we are immediately talking about pathology, of course. And there I'd like to tell you one thing which is important, is if you're not taking care about your sample in the beginning, then you can do the most sophisticated analysis in the end. It's not worth it. So this is the reason why we at Caris, we are specifically cutting out the tumor material of the samples we are receiving specifically. And I just said the keyword is specifically. Consequently, we have very low failure rates. Why is this important? So to say it in a concrete way, of 4 to 6% maximum. So on the average, 5% or what failure rate. So at 95% of the cases, we have results. And the reason why this is important is because in the cancer of unknown primary, if you have, for instance, just only metastasis and you don't know where it's coming from, you don't have enough material, you don't want to have failure rates. So here, pathology, first part, before we even start. The next point now is regarding the diagnostics, because we are in the diagnostics parts. So here, our approach is to use pattern recognition via machine learning and artificial intelligence. What does this mean? Just a little quiz question. So do you see a pattern here? You might say, yes, I see a pattern, a little bit of red here and here and here and so on and so forth. But of course, so this is a gene expression heat map. You can do this with the alterations like gene mutations as well, of course, and everything. So, but of course, if you have alterations which are so tiny, for instance, let's say here a little alteration at this corner, here, and dozens and even hundreds of small alterations, never in life as a human, you are able to integrate this kind of things. Never in life. This is the reason why machine learning and artificial intelligence is so strong and is able to recognize patterns. And you can use this in diagnostics, but also in the prediction of the potential benefit or lack of benefit of drugs. And as a personal statement, so personally, and I'm not the only person who is convinced of this, but I am convinced, absolutely convinced, that the artificial intelligence-based prediction is the future of precision medicine and medicine in general. And if you go to congresses, then you hear it's discussed at every corner. So it's really extremely powerful and extremely exciting, this topic. So how does this work? So this works basically by a combination of what I just said, meaning diagnostics, so DNA, RNA, and then you can also integrate proteins, which are then integrated via machine learning. So basically what we are doing is we are putting into competition different kind of algorithms, and the algorithm which is able to reflect the reality as best as possible to have the best possible outcomes will then be, let's call it the winner of this competition, and will then be finalized and validated. And we did this in the context of cancer of unknown primary. And I can tell you that we have already the second generation of a validated predictive algorithm. So this is called MyGPS artificial intelligence. And it's a combination of integration of DNA data and RNA data. So not only of RNA expression, but as well mutations, for instance, on the DNA level index and copy number alterations. Important to say that this is validated. So it has been validated on more than 12,000 cases. It's been trained on 34,352 cases of genomic data, transcriptomic data, 11,000 cases. So you see it's really thoroughly validated. The accuracy is very high, so 93%, and it can make a differentiation between 21 different cancer types. So for instance, in this case, you have a prevalence of 97%. Of course, what I would not like to say here is that it's the end of it, of it. So it's one important information which you will receive, But of course, pathology, IHC, patient information, your patient file, all of this is important in this investigation of the cancer of unknown primary. But this is one very important puzzle information. And we just published this as well. So it's published as well and validated as I told you. So how can you use this? You can use this for, well, as we just said, at the diagnostic of CAP. But in addition, what you also have to know is that we are using this for a quality control for all the samples we are receiving. So we are always running this in the background. And because, as you know, you do not only have the CAPs, you also have the wrongly or the wrong diagnosed cancers, which are still making up to from 3 to 9%. So you don't want to miss them. So this is also an important point to mention. So a little case study here at this point. A 62-year-old patient, specimen submitted as squamous cell carcinoma of tongue with unusual features. So the immunohistochemistry, the tumor cells were positive for pan-cytokeratin P40, CK56, negative for MAD1, SOX10, S100, P16, and CD45. The outside pathologic diagnosis was lymph node with metastatic poorly differentiated squamous cell carcinoma. So we did our MyGPS on it and found that it's not squamous cell carcinoma, that it is urothelial carcinoma with a prevalence of 100% even. So just to take at the expression of a few markers, so UPK2 expression, GATA3 expression, UPK3B expression. So here you see the expression of the sample in red, here the different medians. So you see it's quite well fitting to urothelial carcinoma. Then you can go back and do IHCs with the markers I just showed, and they were positive. So it was a confirmed diagnosis. Just on a side note, is what I mentioned just 5 minutes ago. It's always important to have a second readout, of course, always when you do when you're working in a laboratory. So in this case, artificial intelligence-based analysis with IHC, and then there was a confirmation. So the diagnosis and treatment were changed for this patient. This was the conclusion. So let's come to the next part. In the beginning, we said this is a two-key system. Now we talked about diagnostic. Let's talk about comprehensive profiling right now. So first question, can we expect to find something actionable in CAP? So of course, so is it worth it? So the short answer, yes. Of course, there are several publications, but I just picked this one, for instance, in order to stay a little bit conservative, because there it's only quote unquote 30%. So it's really significant. So in 30% of the patients here, for instance, in this publication from Pagese et al., you could find something clinically actionable, potentially actionable. So now the question is, if you have a significant population of your patients which have potentially targetable alterations, how can you maximize to find something for your patient? So again, our approach, DNA, RNA, and protein. So why is this so? Let's start with the DNA part. In the DNA part, the simple question would be, if you take a look at these potentially clinically actionable targets, what we just discussed, do you have few of them with a high with a high frequency, or do you have many of them with a low frequency? And of course, all of us, we know this famous long tail of clinically actionable alterations. This is now a general publication from the year 2014. They used whole exome sequencing, and they demonstrated this quite well. But also specifically in the context of cancer of unknown primary, it's exactly the same. So it's just from the upside to the downside. So you see, it's exactly the same. So to keep a long story short, of course, the broader you look, the higher is the probability to find something. And in our case, we're using whole exome sequencing, so you cannot look any broader because we are basically covering every exon. So let's come to the next part. So, okay, what kind of potential target drug associations do you have? On the left side, we will not talk about every one of them, just to give you a little overview. So you have many of them, potentially targetable, which could potentially work if you find them. To give you an example report of a real patient, so of course I removed the patient name and everything. So here in this case, so we found an EGFR mutation. If you take a look at the biomarker level, it will not be a level 1 because level 1 would be companion diagnostics. You would find this, for instance, in lung cancer, okay? So I picked here one example where our MIGPS was not able to find out the diagnostics. I picked this on purpose because then you see what we are discussing regarding the 2 key system. Here, yes, it's precious if you find something what you could potentially target, but still you are interested in finding out, of course, where your prime is coming from. So in this case, it was unfortunately not possible. Still, we found something which then we indicated with the level 3B evidence. So meaning there is some evidence in the literature in another tissue. So this is what 3B is meaning. 3A is in the same tissue, for instance, here for PDL1. So let's continue. Next example. It's again a real life example. So in this case, we were able of finding out where the cancer of unknown primary was coming from. So basically it was colorectal cancer. Consequently, we changed the target drug associations. That's what we were talking about just before, to colorectal cancer. In this case, the outcome was then a level 1 because there was no mutation detected in KRAS and NRAS, and BRAF then level 2. And our artificial intelligence-based predictor in the context of FOLFOX versus FOLFIRI, this is not our topic today, but just on a side note, we have another artificial intelligence-based predictor, which can then give an increased or decreased benefit to FOLFOX for the treatment of metastatic colorectal cancer. So then you have these kind of information which are specific to the tumor lineage. That's the reason why 2 key system. What's also very important, so you want to be comprehensive because it's not only about target drug alterations in a singular way. You also have to think about that there are correlations, of course, with other potential markers. So to give you an example, if you have a KRAS mutation and TP53, you would rather go for immunotherapy. But if you have a STK11 mutation, then you know, okay, immunotherapy is perhaps not such a good idea because there's evidence in literature that it might not work. So you would rather go to chemotherapy. So you see, you want to have a comprehensive approach. You also want to have a comprehensive approach because of other reasons, not only to find the maximum of targetable alterations. You also have it because there are technical reasons for it, which will then lead to a better analysis for actionable alterations for your patient. A good example would be tumor mutation burden. Here, the gold standard to analyze tumor mutation burden is whole exome sequencing. Just look, for instance, at this publication here, demonstrating it quite nicely. Then you think, of course, immediately about pembrolizumab with a cutoff of 10 mutations per megabase. Next example. Here, I have to say, this could be seen as a kind of, let's say, emerging marker, which will become more and more important, but I just wanted to touch briefly on it today. It's Eloh. So all of you, you know what this is. It's loss of heterozygosity. And how you can analyze this, there are different ways of analyzing this, but the reason why it's important, Eloh, is because there are factors which are leading to Eloh, which you cannot analyze immediately via NGS sequencing, for instance, promoter methylation, this kind of stuff. This is the reason why you want to measure Eloh if you want to investigate the status of your repair machinery of your cell. So once again, if you have a comprehensive approach, so meaning whole exome sequencing, you can analyze your single nucleotide polymorphisms across the genome, because then you have them distributed, and we can analyze 250,000 SNPs, so single nucleotide polymorphisms. And this is important because then you have a high analytical quality, so you have a high resolution. But let's continue to the next part. So it's the RNA part. Why do you need RNA as well in order to find the maximum of clinically actionable targets in your cancer of unknown primary patients? So there are technical reasons for it. And please bear with me. I will just take a minute here to explain why this is the case. So if you have a cancer patient in front of you and you are thinking about, okay, it's now, what we are talking about here is, of course, fusion analysis. So gene fusion analysis. You can analyze this on the DNA level only and not do RNA analysis. But the problem is, if you're doing so, you are dependent, of course, on primers. And these primers would then only specifically target the gene fusions, which you know, of course. So the rearrangements, I have to say, the gene rearrangements. But the problem is, all what you are not knowing, you cannot find them if you're not having the primers. So, but it is not the same, obviously, if you are measuring the, let's call it product on the RNA level, so the gene fusion on the RNA level. And this is what we are doing. We are analyzing every transcript. So basically, we are not missing anything. So we are seeing everything. This is the reason why we are doing it. And one of the reasons. The other reason is we can also take the fusion partners and we can analyze the gene expressions, what we just saw before in the context of our artificial intelligence-based predictor of cancer of the unknown primary. Let's come to a specific example where you can see how important this is. Not only to find every fusion in order to target it, for instance, NTRK fusions, we will come to this later on, but also for diagnostics is important. Here again, a real life example of a patient who actually had here an FGFR ENA gene fusion, which is known for cholangiocarcinoma. And our IGPS, artificial intelligence, found cholangiocarcinoma. So you see, you don't want to miss this kind of things. So this is actually also kind of interesting because it's a limited tissue report. This is also one of a proof or example where, what I can show you. What you know, in the beginning when I started talking, I told you that it's very important to take care about your sample. So use microdissection in order to increase the success rate. In this case, it's a beautiful example. Limited tissue, still we were able to have a result because we are performing microdissection. Fusion analysis, we talked about it, and artificial intelligence-based prediction. So this was one example. Here, NTRK fusions, I don't have to explain much to you. Of course, you know that NTRK, it's a tumor agnostic marker, so that's the reason why it has to be mentioned in the context of cancer of the unknown primary. And there you don't want to miss anything. This is the reason why RNA sequencing is highly suggested in this context as well. So a comprehensive approach is leading to detection of more targets, but is this clinically relevant? So the thing is, the short answer, yes. So here you have immediately to talk about the winter trial. The winter trial just answered this question, is it important or not? Do we have a matching or not? And the short answer is yes, because what they did is they had basically two arms, so DNA and RNA. DNA, they were able to match 23%, and in the RNA arm, 12%. So altogether, 35%. With DNA only, it would only have been 23%. And then, of course, you have all the drugs which are going together, so entrectinib, etc. Let's come to the protein part. So here, just as a kind of expression, of course, we are doing more IHCs, but here's only for the cancer of unknown primary. So AR, ER dependent on if it's a male or female, then a HER2 MMR deficiency, which is also quite interesting because you can have MSI stable patients which still are MMR deficient. So you have to measure it. And if you're not doing it, then you would miss these kind of potential therapy associations. And PDL1, we talked about this in the speech before. And now at the end, I'd like to say, it's not only important for to find something for your patient because of the reasons what I just said. It's also in the context of clinical trials, it's important. Because yes, there are drugs which are already approved and which you could perhaps use as a level 3 evidence, but there are more and more drugs which are being investigated right now in clinical trials which you don't want to miss, of markers which are completely new. And this is the reason why a comprehensive profiling is important. And in our case, then we have a clinical trials connector, which will then match the results of the profiling to the clinical trials. But then, of course, please check for the inclusion and exclusion criteria because this cannot be automized. And now as a summary and a last slide. So the comprehensive profiling is needed for cut management because of basically of the two reasons of this two key system for diagnosis on one side, then in combination and in synergy with a comprehensive profiling with all the different subsections what we discussed, so DNA, RNA, and proteins. So thank you for your attention.
Thank you, Dr. Markel. Thank you for a very informative talk. And I think the AI is going to rule the diagnostics very soon. Thank you very much. So I can see a question coming in the chat. If you can address it now. that would be great. The question is coming from Sudipta Sengupta. The question is, for RNA or transcriptome analysis, we require a specific primer to be designed and run through the single-stranded DNA. How come we specify the RNA primers in cup? Can we please highlight it? Hi, Mike. Did you get the question, Michael? Michael, did you get the question?
So basically, could you please repeat the question? But I did not really understand the question.
Yeah, so for RNA or transcriptome analysis, we require specific primers to be designed and run through the single-stranded DNA. How come we specify the RNA primers in cup?
No. So it's not like this. Please give me 1 second. I will go back to the slide. So here was the diagnosis part. Here this part. Then let's come to the RNA part. Okay, it was this. So basically here, the situation is the following. It's for the DNA part that you need the specific primers. So the thing is, of course, you have these large introns, okay? And if you have these large introns, and also then generally regarding this DNA sequencing, you need your primers for the DNA part, of course. But because in our case, we're analyzing whole transcriptome, so meaning every transcript, which is then independent of the primers, we are basically covering everything.
All right. So I hope the answer is clear. So, Michael, is this technology available for Indian patients as of now?
Yes.
So can we ask
I'm sorry. So the thing is the following. Everything what I explained today is systematically done in every Caris test. So I'd like to say that there is a distinction. The only distinction there is every Caris test we are doing has systematically whole exome sequencing, whole transcriptome sequencing, and every signature which there is. Meaning GPS analysis, we're doing this on every sample, and tumor mutational burden, MSI, is always integrated. The only thing which is not systematically there are IHC analysis, which might either be included if you are ordering the full profile, or if you are ordering the, let's call it light version, so the small version of it, you will receive everything what we discussed today, but just perhaps a few IHCs, you will not receive them.
So do you always provide LOH percentage in every report?
Yes.
Along with the TMB and along with the MSI, correct?
Exactly. Everything systematically. So we are really very comprehensive systematically.
Perfect.
For the reasons we discussed today.
Yeah. Thank you very much. So
thank you.
We'll go to the panel discussion. It will be a clinical-based discussion, and I would like to invite all the panelists, and all the speakers can stay back for the panel discussion. And Dr. Ashna Lal, Dr. Arun, and Dr. Piyush Vajpayee, please join the panel discussion. Dr. Rajat, he's the moderator, and he will take it over now.
Okay, so I'm sorry I have to go, as we discussed. So I wish you a good evening. Bye.
Dr. Rajat, Michael needs to leave.
Yeah, please.
If you can ask him a few questions before he leaves, that would be nice.
I think so. He has comprehensively covered a lot of things and actually enlightened us on a lot of new technology-driven diagnostic approaches. So I think so. I would admit that we are currently still basing our diagnosis on our traditional ISC, we have still not started using the whole transcriptome evaluation, and obviously the use of AI in actually picking up certain different patterns. So that is definitely a very enlightening talk, and I would have loved if Dr. Michael would have been there for our real life case scenarios, but if he has to leave, I think so we have the rest of our learned panelists are already there.
Thank you very much.
Thank you very much. So,
Thank you, Michael. Yeah.
thank you, Dr. Amit, and thank you, Dr. Rao, for inviting us to this very, very important topic of the cancer of the unknown primary. And we have, I'm very lucky to have our learned panelists, because in this situation of unknown primary, we always require very, very cooperative colleagues who are able to discuss it out means for our patients, for the benefit of our patients. So we have Dr. Arun Goyal in the surgical field. We have Dr. Piyush Bajpai in the medical field. Dr. Piyush is there, I think so. Dr. Amit Verma is our molecular oncologist. Dr. Ajay Vyas is there as our nuclear medicine specialist. Dr. Rajiv Tangri and Dr. Archana Lal will give us the very, very required pathological support. So let me just begin the. So basically, CUP is like a dark room. We are always probing like that, and we as clinicians just try to search for a ray of light, and then we are able to guide our patients. It is very difficult to treat a patient without actually giving a diagnosis. So it's the basic insecurity of our clinicians like us. We have to get a diagnosis. So let us begin. These cases are very basic cases. I have a collection of 3 cases, real life cases from my practice. This is Mrs. M, a 45-year-old lady who presented with a large left supraclavicular swelling and a left axillary swelling. So this was the thing with which she walked into our clinic. And Dr. Piyush, if you are there, we can just have the rundown on how do we investigate her.
Yeah. So this is that we saw that there is an axillary and a supraclavicular lymph node in a 45-year-old lady. So one of the things which comes to my mind is ruling out a breast primary. So if there is no palpable mass, of course, in a 45-year-old, I would like to consider for an MRI breast. That is one important investigation I would want to include. Apart from that, of course, going ahead with a biopsy and immunohistochemistry profiling would also be necessary. If I'm not able to find a primary in the MR, I would also consider a PET CT further, and the tumor markers.
Correct. Perfect. So, Dr. Ajay and Dr. Piyush, we are all currently practicing in tertiary cancer care centers. So quite often our patients actually walk in with a PET CT scan to us. So we did not focus on a stepwise imaging algorithm like an X-ray or a CT scan. Generally, they come with a PET CT scan, and Dr. Ajay in his talk has conclusively proven that PET CT scan is very, very important in actually picking up the primary. So Dr. Ajay also showed us a series of cases in his presentation. So I just want to ask him a few pertinent questions. I could not gather the PET CT images of this patient. My apologies, because this was a 3-year-old case. So Dr. Ajay, how do we differentiate the primary and or the metastatic sites based on the SUV uptake? Is there any way of differentiating between the primary? How do you say that this is a primary, this is a metastatic?
So actually, both the SUV max values and the size, we cannot predict the primary from these tools. These are basically initial thought when the first time PET CT was come, that the SUV of the primary is more than metastasis, but it's not right. Right now we are a decade ahead, And I show the case there's a small primary with large lymph nodes. So first of all, we have to see for this in the particular patient is a supraclavicular lymph node, so either is from the, it can become from the head and neck as well as from breast as well as from the abdomen side. So definitely PET-CT is useful in this case, and breast MRI.
So let us just proceed ahead. Now we can see here that the PET-CT scan showed a conglomerated left supraclavicular lymph node, left axillary lymph node, periduodenal lymph nodes, mesenteric lymph nodes, right external iliac lymph nodes, and a peripherally enhancing right ovarian cyst measuring about 2.3 centimeters. Dr. Piyush had also ordered for certain basic tumor markers, and the CA125 was 82, mildly elevated, CA19.9 was 30.3, and CEA was normal value 0.9. So now, based on the PET-CT scan and the tumor markers, Dr. Piyush, how do we further investigate her from this point onwards? And at this point of frankly speaking, I also did not have any indication as to how to, at least looking at this picture, there is no obvious hint of a primary in this case.
There are multiple lymphadenopathies. That's what we can see.
Yes.
There is no organ of involvement which is being probably defined over here, except for a peripherally enhancing right ovarian cyst. There is no organ of involvement, what we can in particular say. So I would like to consider a lymph node biopsy, and left supraclavicular is one of the sites I would like to consider my surgical oncology to consider for a biopsy.
Perfect. So that's what we did. Now, in addition to the biopsy from the supraclavicular.
So Dr. Rajat, I want to intervene here.
Yes, please.
So we did the MRI of the breast to look for the breast primary, fair enough, and we did the PET-CT whole body.
Yes.
But if you talk about the possible primaries, because I can see the CA19.9 is also a little raised, and we have abdominal lymph nodes with supraclav. So a possibility of pancreatic should be considered, and either abdominal imaging or high sensitive abdominal imaging like MRI abdomen should be considered also actually.
So now the norm basically, do we believe the PET-CT scan, or on top of that, Dr. Amit, you would like to do a high sensitive MRI?
Yeah, so exactly, because right now the most of the primaries what we miss in the CUP is either coming from the lung or the GI or the pancreas most of the time.
Correct.
So once we are not able to pick up from the PET-CT, which we know they are not that highly sensitive in terms of small size, or if the primary is lost, I think MRI abdomen warrants in this particular case, seeing CA19.9 little range.
Fair enough. We can definitely investigate further from the imaging point of view. But now let us see what we get a hint from the pathological point of view. So we, in addition to the biopsy from the supraclavicular lymph node, which picked up a poorly differentiated adenocarcinoma, we then ordered for a colonoscopy and an upper GI endoscopy. Both the colonoscopy also picked up a thickening in the upper rectum, the biopsy of which revealed a metastatic deposit of adenocarcinoma, and the upper GI endoscopy also picked up a thickening in the antrum, and the biopsy was again poorly differentiated adenocarcinoma. So here we have a biopsy from 3 different sites, all picking up a poorly differentiated adenocarcinoma. Still, Dr. Arun, do we from this information have any hint of the primary as of now?
Dr. Rajat, the only thing is the endoscopy findings. Was there any mucosal ulceration in any of the sites, or
no? There was no mass lesion. There was no mucosal. It was a thickening in the antrum is what was reported. The endoscopist found it a little suspicious, and he took bites from that area.
They can be serosal deposits also.
So now the question is maybe the pathological picture, whether the picture is from a sort of infiltration of tumor from the outside, whether the tumor is a submucosal deposit or whether it is a mucosal tumor. So that pathological picture would probably help us there if it may. Another thing I just wanted to comment about additional imaging. So definitely high sensitivity imaging is something which is important. Now the question is, do we do that imaging prior to pathological assessment and having some indication as to which site we should look for with a high sensitivity imaging, or do we do that imaging prior to biopsy? So probably in today's times, a biopsy and some indication as to which site to target could also be useful in targeting additional imaging.
Correct. I fully agree with Dr. Arun that first we need to get the information, maximum information from the biopsy, and then biopsy followed by IHC, and then we can again redirect our imaging based on that. Correct. So here, Dr. Rajiv, one important point which Dr. Arun has asked is whether these are serosal deposits coming from outside, or are they mucosal or submucosal deposits. So if we give you a biopsy, would you be able to tell us whether these are serosal deposits or whether they are mucosal deposits, just from the histopathological analysis?
Yeah, so it will not be possible in 100% of cases. But yes, many times we are able to tell that from an endoscopic biopsy, because endoscopy obviously will not take serosa will not be included, so it will only be mucosa. So if the mucosa, if we get intact pieces of mucosa with intact epithelium, and there are, I mean, in some mucosa there are deposits. Or many times we get lymphovascular emboli, and with intact mucosa, we do presume that it is probably a deposit, and that is what would have been in this case, because I could see the biopsy report as metastatic deposits of adenocarcinoma in a colonic biopsy.
Correct. So probably that the mucosa, if what you're trying to emphasize is, if you find that the mucosa is intact, then you may presume that it is coming from the external surface.
Because yes, and since it's an endoscopic biopsy, there are multiple small bits only. So and we cannot see origin in that biopsy. So we can only presume, because many times, even if it is a primary of that site, the origin may be somewhere else. It may not be seen in that particular biopsy bit.
Correct. So, Dr. Rajiv, you had extensively elaborated on the markers of CK7, CK20 to actually differentiate between the primary sites and combined with CDX2. So this was the extensive immunohistochemistry panel which was done in our patient. And if we can see, if I can just point out the positive markers from this one, this was CK7 positive, this was CK20 negative, synaptochromo negative, and Ki67 is 80%, mamma globulin is negative, the melanoma markers are negative, and the ovarian, traditional ovarian markers like WT1 is negative, PAX8 is negative, CDX2 is negative. So you can take about 5 seconds, Dr. Rajiv, to actually read the report. And how do we go ahead with that?
Yeah, I'm just.
And my pathologist here has finally commented that kindly investigate for primary in the pancreaticobiliary tree. So that is what Dr. Amit Verma was also hinting after the reading the PET scan report and the marker report. So that was what they were asking. Kindly look for a primary in the pancreaticobiliary tree.
Right. So with this kind of profile, I think the only marker missing with CK7 positive and CK20 negative here, I can't see TTF1 here. Though nepsin is there, nepsin is negative. But sometimes, I mean, we do see cases which are only positive for TTF1. But yes, if we combine it with the radiological imaging findings, does not look like a lung primary. Looks like a GI primary only. CA 19.9 is focally immunoreactive, so would go with this diagnosis of possible primary in pancreatic biliary. Unfortunately, we don't have any specific markers available for pancreatic biliary primaries. So we go by CA 19.9 positivity, CK 19 positivity, 7 positive, 20 negative profile. Sometimes CDX2 can be focally positive in these cases, but in this case it was negative. So basically ruling out all other 7 positive, 20 negative tumors and with focal positive of 19.9 points toward that of pancreatic.
Okay, fair enough. So we took this. We did not do the specific imaging which Dr. Amit was suggesting. We took it to be a pancreaticobiliary primary, hidden pancreaticobiliary primary, occult primary, and then we gave her 2 cycles of FOLFIRINOX therapy. So after 2 cycles of FOLFIRINOX therapy, she progressed. So her left supraclavicular lymph nodes had progressed. So then we thought we'll change track and started on paclitaxel and cisplatin. This is the standard treatment regimen. Paclitaxel, cisplatin plus minus etoposide is the standard treatment regimen for any MUO. She luckily responded after 3 cycles, went on to complete 6 cycles. So Dr. Piyush, you would agree with my line of treatment here, means till now?
Largely, yes.
Or would you have done something different for her?
I would have looked at if just prior, and I'm sure you would have done that. I would have wanted to look at the tissue agnostic markers before starting FOLFIRINOX, which are in our clinical domain, including the MMR and also since she's a young female and breast primary has not been, I mean, a breast as a CUP has not been entirely ruled out. There was PR focal positivity. So I would also like to consider any BRCA-ness or an extended hereditary panel probably.
Okay. So what you are suggesting is, number one, we should look for tumor agnostic
marker.
Tumor agnostic markers and probably check for the BRCA-ness and other things.
Or some, yeah.
Correct. So unfortunately, this patient.
So my question to Dr. Rajat, is, yes, when we started with FOLFIRINOX, assuming it is a pancreatobiliary, and the patient didn't respond, and then we went to Pacli cis.
Yes. Doctor, we have lost you. Huh. We can't hear you. You're trying to say something. I can't hear you. So, okay. So I think so.
Dr. Amit, we are not hearing you.
I think so. We have somehow lost his. All the rest of us are able to hear each other.
Yeah.
So patient progressed after 2 months, and on progression now the important things is now after progression on the we again did the rebiopsy, and it was HER2/neu positive on the supraclavicular biopsy specimen. So this is a very interesting thing, because if we can see the initial histopathology report where HER2/neu is reported as negative, and subsequently on rebiopsy on progression, we again did, then the HER2/neu turned out to be positive. So again, there is a discordance in the initial pathology specimen as well as on the repeat specimen. Dr. Rajiv, would you like to comment on this? Have you seen this?
Before this, Dr. Rajat, was the initial IHC also on the supraclavicular lymph node biopsy?
Yes.
Okay, it was.
So There
so
is
was
an importance.
Yeah, so was other markers were also done, or it was only HER2 that was done on this biopsy?
This time we because it was a desperate situation, we were checking for basically the actionable or the druggable mutation. So that is what we were trying to do. From all the talks which I have heard previously is basically we now have to actually check for two things. One is the tumor agnostic markers, as well as the actionable or the druggable mutation markers. So that is what we did later on in our patient after progression, but maybe we should have done it previously. However, in this case, we did the HER2, it was negative. So, Dr. Amit, are you back?
Yeah, I'm back. So I can
And
see that
HER2
your
earlier
report
was
says HER2 was positive to begin with, now negative. I just missed the.
No. HER2 was negative to begin with, and now we did a repeat biopsy on progression, and then it turned out to be positive. When I was specifically looking for the actionable mutations.
Excellent. So I think you were lucky to pick up these things.
Yes.
So
And
sometimes, sometimes I think I personally do not know if there's any selection of HER2 clones like this. But I think the first HER2 analysis was might be a miss. But having said that, definitely there are possibilities which can happen. But I think that might be a miss. But in terms of testing, you're asking another question which I can see on the slide. So I'll just address it right there. So role of testing for.
Yeah, one thing I would like to add here, I mean, I understand both would be true cut biopsies. So the staining is many times patchy. Even if we see a large tumor and we do it on a large biopsy, it's not that the HER2 staining is uniform throughout. I mean, that would be true even for ERPR. So maybe the initial bits that were taken did not show a positive staining, while the bits that were taken later on showed some positive staining. I mean, I understand it must be 3 plus only, the score 3 plus only to call it positive. Yeah, but yes, there may be some cases wherein post therapy, I mean, mutation post therapy and cannot be ruled out. Rare
Dr.
cases,
Amit,
but yes.
Yes. So, Dr. Amit, are you in favor of testing for actionable or druggable mutations in every case of CUP upfront, rather than giving the standard chemotherapy?
The answer is big yes, because we understand that the cup, 80% of them will behave so poorly that you won't have much time to treat them later. So I would personally, when you label them as cup, I think we should go for upfront analysis, genomic profiling to identify the actionable target. You start with your chemotherapy. If your first line fails, you jump to your target therapies, whatever comes in a way. So that is my personal opinion on that.
So that is the important learning from this case, that we definitely should look for actionable mutations upfront rather than trying to look for them on progression. So that is the clinical paradigm shift which we are nowadays undertaking. So
Doctor,
this is another.
Can I please add one thing for this case for the mutation testing? It is advisable to go in for a comprehensive molecular profiling right up front, because what happens is that with chemo and radio, the amount of tissue we get becomes negligible over time. And then we cannot do any genomic testing on these tissues. So in most cases, it is also good to just go bang on and get everything done at one go to look at it. Of course, things change with treatment and targets will change with treatment, and that's unavoidable.
Correct. So that is the learning which I have taken, because this was a 3-year-old case, a case which we treated in 2018. We were not very much involved with the comprehensive genomic profiling, but nowadays, definitely, I would like to look at this case in a different way and probably do it upfront.
Dr. Rajat?
Yes.
Can I ask a question which would may be slightly uncomfortable, in the sense that as clinicians, when we see a patient, we know technically looking for actionable mutations, tumor agnostic markers, having comprehensive genomic or multi-omic analysis is the way to go. The question is, if we see the price range at which these testings are available, as of today, it becomes beyond the reach of majority, almost all of our patients. Now, can we have some opinion from Dr. Archana, Dr. Rajiv, and even Dr. Amit? What do they see as the price trend? Are we going to have increased affordability in these investigations? Well, I want to do it for every possible case.
Yeah, Dr. Archana, you would like to take
Yes,
up this?
Dr. Arun, I completely understand, and that has been the biggest issue with genetic testing, and that's another reason why genomic profiling has not taken up in a big way. I see that with time, it will definitely come down, the pricing.
Okay.
Part of the issue is that a lot of the sequencing tests we do on Illumina and the reagents, they cost so much that we have to up our prices to just get some sort of margin. But I think to begin with, if a patient cannot afford anything, yes, the basic mutation panel, the 5 or 10 actionable mutations should definitely be tested.
Okay.
And then over time, hopefully prices come down and more things can be done.
Yeah.
So I have another opinion on this subject actually. Though the cost of the test is definitely higher at this point in time, but it is worth it, especially for the CUP, knowing a poor prognostic diagnosis, I think, and wasting the patient's resources on the chemotherapies or different lines of treatment. I think that is a sheer waste of time and money. On the other hand, if the patient can truly afford target therapy, which we can evaluate at the time of first diagnosis, I think the cost effectiveness of these investigations comes very handy. If the patient cannot afford target therapy or immunotherapy, then definitely there is no role of doing all these investigations at all. So we have to judge the patient. If the patient can afford target therapy or immunotherapy, then these investigations should be offered as early as possible.
So because of want of time, I would just like to ask a few pertinent questions with the permission of the panel to Dr. Rajiv. Can I ask you one question? Our pathologist always comments that because of the very poorly differentiated histology on the biopsy, the tissue is likely to lose out on the IHC marker. So is it true? Means ultimately, is the IHC giving us a right picture? They say that undifferentiated or poorly differentiated neoplasm generally do not take up the stains they are supposed to take. And how do we then interpret these kind of cases?
Yeah, I mean, yes, the poorly differentiated neoplasms. So as the differentiation, they start losing the differentiation and more poorly differentiated or undifferentiated a neoplasm is, more likely that it will lose the antigenicity. So yes, that is true. Not in 100% of cases, but I think the basic lineage specific markers we should get. I mean, in most of the cases, but yes, we do encounter some cases wherein we can't get anything in the biopsy. We do multiple markers, IHC markers, 10, 15, 20, but not able to arrive at a diagnosis. So only thing that we can say is poorly differentiated carcinoma. There are some antigens which are more hardy. They stay even with very poor differentiation. So the basic markers will remain. I mean, cytokeratin will remain, LCA will remain, vimentin will remain. But more tissue-specific, lineage-specific markers, they start losing antigenicity and with more and more poor differentiation. And of course, it is very important that the tissue that we receive is properly fixed, adequately fixed, neither overfixed nor underfixed. So, because that is one big factor for us not getting IHC markers properly in the tissue.
So, question to Dr. Archana. Dr. Michael Foss in his lecture had commented on the role of number one, micro dissection of the tissue to enhance the yield of the tumor cells, number one. And secondly, he proposed a reverse diagnostic platform. He first was doing the comprehensive genomic profiling and then was confirming it by doing the traditional IHC markers. So are you in favor of it? Are we looking at a reversal of our diagnostic or our pathological diagnostic panel in the near future?
Yes, we are, definitely. The whole idea is that every test can confirm the other test. So if we're doing microdissection, we're just taking out the tumor cells. So then we're sure that we're only testing tumor cells for genomic profiling. And once we have a molecular profile that is being vetted by the AI, it is good to go back to IHC to look at the histopath and see if that matches. And I think in the coming years, this will help with more research and getting more biomarkers ready for more testing. So it's definitely helpful.
So that is one paradigm shift which we are kind of looking at during our practice, that we may have to go the reverse way, because he in his lecture showed a case which was reported as a squamous cell carcinoma and ultimately turned out to be a urothelial carcinoma. So there is a total change of treatment line based on these two contrasting reports. So I may not go on to this case. This is just another case actually. Dr. Amit, if you could just highlight on the tumor agnostic approach. So are we okay in chasing the tumor of origin, or we can just go on to the tumor agnostic approach to treat our patients?
So I think a tumor agnostic approach is appropriate, but also we need to have the primary site if possible. So the biomarkers, what you have just mentioned in your slide, the MSI, TMB, and TRK, they show very good responses irrespective of the primary site. But when we go to level 2 evidence biomarkers like BRAF mutation, so if you use a BRAF inhibitor and the primary site is different, like say colon versus thyroid, you may see a dramatic difference in the response rate. So depending upon the primary biomarker and the information what we have, it would be nice if we can have the primary site as well as the biomarkers to predict the response also. Not only a treatment approach, but the response rate can be also predicted in a well advance. So, but having said that, tumor agnostic approach is a must, and we have 3 biomarkers which are approved by FDA, which can be used for all pan cancers actually. So,
correct. And Dr. Foss had also enlightened on the upcoming role of the Eloh markers also. So those will also definitely come into the picture. So Dr. Archana, we traditionally believe that the CUP generally behaves in a poor fashion. So any specific genomic alteration or mapping which we have seen in maybe a series of about 50 or 100 CUPs, which points out to the fact that it is behaving badly as compared to other
Yes,
sites.
fairly recently there was a study that was a 50 gene panel study where the researchers found that TP53 mutations led to a marginally shorter overall survival with a better prognosis in TP53 wild type cases, especially in females. And they also found that KRAS and CDK and 2A mutations conferred a very poor progression-free survival. But this has been the only study that has been done for prognostication in CUP. I have not come across any other studies that look at alterations. So we'll need more data to come out. We'll need larger sample sizes. We'll need better trials to figure out a specific signature for CUPs that indicates a poor prognosis.
So Dr. Piyush, you're there?
Yes, Dr.
So yes, definitely the poorly differentiated adenocarcinomas per se are the unfavorable subsets of the CUP. Now, obviously, there are various favorable subsets of CUP also. If you can just, I think so, highlight on the few favorable subsets of CUP.
Just put in the first one, the peritoneal carcinomatosis. We can actually treat more like a serous epithelial primary, like we treat ovarian carcinoma. And then women with axillary lymph node metastasis, you just discussed that they have to be, the breast primary has to be just kept at the back of mind somewhere. And then, of course, you have just showed this one that in an elderly male with the retroperitoneal lymph nodes or any PSA, something that needs to be looked into. Of course, then there are sites like inguinal adenopathy also, which is important, where we need to look at the anus, perineal region properly. And of course, there is midline tumors in young males, which is important, where we need to look at extragonadal germ cell tumors, so they can be treated quite well. Of course, squamous cell carcinoma of cervical and supraclavicular region, again, head and neck primary and the esophageal, so pan endoscopy becomes very important, and they are a good set of primary. Also, CA nasopharynx needs to be ruled out in such situation. Low-grade neuroendocrine tumor, again, yes, they are again a favorable subset of tumors where we can actually get good response rate, good efficacy in terms of treatment. Yeah.
Correct. Good.
Dr. Rajat?
Yeah, Doctor.
I want to add an important point here for the imaging point of view. In case of gross ascites and gross pleural effusion, so sometimes because of the effusion and ascites, the primary site is hidden because of peritoneal and serosal deposits in case of ascites and in case of CA bilateral ovary. And in few cases, what we see after the 3 cycles of chemotherapy, we actually got the primary after because the ascites become less, the extent become less, and we just like in CA lung also with pleural deposits actually and the gross ascites, we don't find any primary on the first imaging, but after the 3 cycles of we got the primary. So
yes.
you have to take consideration of ascites and effusion in case of cups, actually.
Correct. So this was another case, basically a squamous cell carcinoma of the head and neck primary, which we had discussed in our previous lecture also. And yes, Dr. Rajiv had also indicated as regards the importance of basically the triple endoscopy. Dr. Arun, if you're there, basically the triple endoscopy. And obviously the caveats of the triple endoscopy are some blind spots in the fossa of Rosenmuller, the pyriform fossa, and the tonsillar crypt. So these are the blind spots which are there in the triple endoscopy. So just coming to the last part of the panel discussion, this was one paper which was published in ESMO 2019. Basically, this is the phase 3 trial of empirical chemotherapy with cisplatin gemcitabine or systemic treatment tailored by molecular gene expression analysis in a C-cup case. So here, basically, somehow this was a negative study. This study showed that using the molecular test followed by the tailored systemic did not improve outcome in patients with CUP. Dr. Archana, if you could like to comment on this negative study. This was not expected, but yes, it came out to be negative.
I have come across one more study, which was actually a phase 2 trial, which was similar in that they had tested gene expression analysis, which is your
this is the study you might be actually looking, Cupisco study, phase 2 study. This is what you're referring to?
I think so, yes.
Yeah, so this was a positive study.
Okay. I can't remember the name of the author, but they had also said that site-specific therapy determined by gene expression profiling did not result in significant overall survival for a year or progression-free survival compared to empirical paclitaxel carboplatin. And that's what begs the question that should we be focusing on gene expression analysis solely, or should we also look at comprehensive molecular profiling so that we get an overall picture of the tumor and the metastasis? Part of the problem is that cup tumors are so poorly differentiated that any RNA analysis becomes very difficult, which is what gene expression tests use. RNA gets destabilized very quickly. So that could be one reason.
Correct. So overall, the tissue of origin test, which was quite in vogue maybe about a year back, I think so have fallen out of fashion. Means we generally do not order these specific tissue of origin tests. Is it not, Dr. Piyush? I don't think so. We are ordering this kind of test anymore based on gene expression profiling.
You're muted.
It is slowly. In fact, I had a bad experience. I had sent this particular test, and it seems that the company stopped doing it, and the whole thing was held up for almost quite some time. So the block had to return, had to be returned. Yeah.
So nowadays these panel of tests are obsolete, I would say, and a more comprehensive
genomic profiling makes more sense.
Makes more sense. Yes.
Yeah. So let me correct here. So the intent for the initial thought process that if we find the primary site, we may treat them better, and the whole idea was selection of the chemotherapy choices what we had. But now the paradigm is changing, that we are not looking for the chemotherapy combination, which is the better one, but rather we are looking for target therapy or the immunotherapy or combination of the chemotherapy with the target therapy. So in that case, comprehensive genomic profiling gives you a better, you can say, the results in terms of finding more actionable targets. And definitely you will find a lot of studies which are in favor of the molecular profiling and going against molecular profiling in terms of the outcome. But having said that, we are in a learning phase how to use this molecular profile to tailor-make the treatment. There is no standard guidelines how to apply it. So we are learning. So we may get some more good answers maybe later. But for now, this looks like to be a hope actually.
Correct. So I think so with this, I would like to end the panel discussion. The basic learnings from this panel discussion has been, which for me has been basically definitely a good clinical radiological pathological correlation is required. I think my learned panelists would definitely concur with this. The tissue of origin test is not in vogue, and we are kind of phasing this kind of panel out. A panel of actionable mutations or driver mutations should be done in all cases of CUP upfront rather than later on progression is what I have thought. Molecular profiling, comprehensive genomic profiling, a whole transcriptome profiling needs to be done in almost all the cases of CUP. So that is and obviously when we are doing the molecular profiling, complete comprehensive genome, we are definitely coming across the various tumor agnostic markers, which definitely will guide us confidently in maybe starting any immunotherapy or any other therapy. So with that, I think so we are coming to the end of our panel discussion. Any other thought process, any other questions in your mind, we can discuss it out right now.
So I wanted to also bring the role of liquid biopsy in CUP. As we know, sometimes the metastatic disease, we have so many lesions. So what to biopsy and what to investigate sometimes becomes a challenge. So liquid biopsy also is very handy to identify the actionable targets if somebody wants to get it through. And also the level of cfDNA, the CTC levels also predicts a lot many prognostics information, as well as there are certain biomarkers like MSI and TMB can also be done on the liquid biopsy, which can be very important. So I think liquid biopsy is also a way if the biopsy is not feasible.
Thank you. Thank you very much. Thank you.
So thank you, Dr. Rajat. So I think I will ask Dr. Arun for the closing remark, and then we will quickly close the session. A wonderful session and wonderful panel discussion.
Thank you, Dr. Amit. First of all, Congratulations for organizing this very nice and pertinent event. And I think we had a very good audience today and people have stuck till the end. My only message is that the field of molecular oncology is a field which is in a sort of continuous evolution. On a everyday basis, new information is coming. And another important thing is this, the knowledge base. As it grows, we become better at predicting what works and what doesn't work. So probably over the coming years, one, with increasing accumulation as the maturity of knowledge occurs, the prices definitely will come down. The cost of testing and the cost of treatment both would significantly come down. And at the same time, the accuracy of our predictions is going to increase. So definitely it is a field which is going to sort of probably be the dominant driver of the gains that we are going to make in cancer care in the coming years. And my personal feeling is that over next couple of decades or so, probably chemotherapy might be totally outdated and it will be only targeted therapy which will work based on comprehensive assessment of every tumor that we see. I think with that, I would like to say we should really keep on learning about the field of molecular oncology, and Dr. Amit would keep on organizing events that increase our knowledge in this field. With that from my side, that's it. Thank you once again. And I would like to thank all the supporters for the event. Dr. Amit, if you would like to say anything more about that.
Nothing much, sir. Thank you all, and thank you all the attendees for attending for so long. And we exceeded the time, and I think it was very interesting discussion. And I personally enjoyed and learned a lot. So thank you very much. And we'll organize new, you can say, avenues in other aspects of oncology, especially the molecular aspect. And thank you all once again. See you next time. Yeah.
Thank you.
Thank you.
On behalf of Oncology Forum, I would also like to thank all the speakers and definitely Dr. Amit Verma for organizing such an interesting conceptual talk, and looking forward for more such webinars. Thank you, everybody. Thank you, sir.
Thank you, Dr. Amit. Thank you, Arun, sir.
Thank you.